there are two muscles. Both of them have the insertion onto the heel bone, the calcaneus. The superficial muscle is the gastrocnemius. And if you look at cyclists especially, this will be quite large, but the soleus can still be seen down here when it's developed. And the soleus is the deeper muscle that doesn't cross the knee joint. All right, so we're just doing gastrocnemius. And since it crosses the knee joint posteriorly, it is going to flex the knee. And it also crosses into the foot. All right, so we have two more sets of joints now to pay attention to movement. So at the knee, like the elbow, we have specifically just for the elbow, we only have flexion and extension. Okay, that's all the elbow does, specifically between the humerus and the ulna. So the knee between the femur and the tibia is flexion and extension. We're not going to do the slight rotation. That's what our plantaris muscle does that we're not talking about. So at the knee, the gastrocnemius is going to do flexion. And then when we get to the foot, we have two sets of movements that we haven't really talked about yet. Similar to the hand, but we have different terms. So first of all, we have pulling the toes up. Now, if we pulled our fingers up like that, that would be extension, and this would be flexion. We call them both flexion in the foot. So pulling the toes up is called dorsiflexion. We're moving the dorsal surface of the foot up. And then pointing the toes down is plantar flexion. So unfortunately, the label here stays a little bit too long, but I'm not sure how I captured it if I put it up on a PowerPoint. So toes up is dorsiflexion. Plantar flexion is coming up, and that's going to go, come on, move. That's plantar flexion, okay? So if you're up on your tippy toes, or if you're dancing, you're on point as a ballet dancer, that's plantar flexion. Dorsiflexion is walking around on your heels, okay? You push your toes. So when you walk, you push off with your foot, and that is plantar flexion, okay? And then you flex your thigh, extend your knee, and now what are you going to do at your foot? Plantar flex or dorsiflex? Dorsiflex, so you can come down heel first, okay? Then you plantar flex again, extend your knee, dorsiflex, and come down on your heel, all right? So toes up is dorsiflex, toes down is plantar flex. Then, for the hand, we had supinate and pronate. Supinate was cup, like a cup of soup. Pronate was face down, like you're lying prone. Similar movements for the foot. So if this is my foot instead of my hand, we use inversion and eversion. However, if you're a runner and you go buy shoes, fleet foot or whatever, they're going to ask you if you over-pronate or under-pronate. So this is pronate for the hand. So over-pronating is rolling your foot inward, and you're going to wear out the inside of your heels and lift the outside of your foot up. So for our terminology for that is eversion, the outside of the foot coming up, okay? So if my thumb is my big toe, then if I roll my foot in like that and my outer foot up, that's eversion. Underpronation is if I was starting to supinate my foot, turn the inside of my foot up, bring my big toe off, that's inversion. The instep coming up, okay, is inversion. So if you're a runner, the term for that is underpronate, okay, wearing the outside. That's what I tend to do, is wear the outside of my heels out, okay? So those are the new terms that we're going to use for foot movement. So gastrocnemius at the knee is going to flex, and then anything that's behind you, remember the medial and lateral malleoli line, the two ankle bumps? If a tendon is behind those, it's going to pull the back of the foot up and point the toes down. So any group of muscles, and we have two compartments that do that, the posterior leg and the lateral leg, do plantar flexion. To do dorsiflexion, the tendons have to be in front of those two bony processes. Okay? So gastrocnemius attaches to the calcaneus, not to the medial or lateral aspect, and so it's just going to do plantar flexion, toes down at the foot. Okay? Then, the only, to me at least, the only difficult or the more difficult area of the lower extremity is the posterior leg. just because it's not the way you would expect it to be. So here would be we'll do this on the right leg again. Well, what leg what are your models? Are they, what's your left leg? We'll do a left leg. You can match it to your models. So if it's a left leg, this would be the tibia. And this would be the fibula. Okay? And we'll just point the toes down to begin with since we're looking at posterior. That's a foot. All right, so we've taken the gastrocnemius off. All right, and we're looking at the deep layer. And these tendons are going to go around the medial malleolus to get into the foot. So we're going to flex the toes, the big toe, the little toe, and we're going to have a muscle that comes to the instep. So the most medial muscle, all right, the one on the tibial side, the one that's on the big toe side, the most medial muscle, and I am not going to be testing you on origins for this, it actually goes farther over than that. Its tendons come down and go all the way to the tip of each of the 4 toes, digits 2, 3, 4, and 5. Notice they come in at an angle because they're going around the medial malleolus. So this muscle is flexor digitorum longus. Brevis is going to be in the foot. It is homologous. What was the muscle in our forearm that sent tendons all the way to the tips of our phalanges and our fingers? Flexor digitorum profundus or superficialis? Profundus. Superficialis had the fork. The equivalent of flexor digitorum superficialis is actually in the foot. Okay? So we're not learning that one, but we're going to learn a muscle that works on it. So flexor digitorum longus goes all the way to the toes. So it doesn't cross the knee, so it's not going to flex the knee, but it does cross the ankle posteriorly. So it's going to plantar flex the foot as it crosses behind the malleoli, and it's going to flex the toes. Okay, then we have a muscle that goes just to our big toe. We do it in the forearm as well, we just didn't learn it. Flexor pollicis longus. But remember we said we had adductor pollicis and abductor pollicis, and we said the word for first finger was, the first digit, the thumb was pollux or pollicis, and our big toe is hallux or hallucis. And I talked about halitosis, so remember your big toe is more likely to stink. So the muscle that flexes the big toe actually starts on the lateral aspect of the leg, backwards from what you would think it ought to be doing. And so this muscle is found on the fibula side of your posterior leg. And it goes all the way over to the big toe. So because it crosses the ankle in the back, it's going to do plantar flexion. And it's going to flex the big toe. So they're on opposite sides of where you think they should be. They're not on the same side of the muscles that they work. All right. Then our middle one, we only see a little bit of because of these 2 big muscles. And its tendon comes here to just about, we're going to say the first metatarsal, although it's just barely there. And this muscle is the tibialis posterior. Crosses the ankle posteriorly. So it's going to flex, plantar flex the foot. And doesn't go to any digits. So it's not going to do anything at the toes. But it goes to the first metatarsal. So is it going to invert or evert? Invert. big toe side of the foot up. So it's going to do inversion of the foot. Okay. So if we look at, this is not the model you have, but this is medial malleolus over here. So this is flexor digitorum longus. A little piece up here is all we see of tibialis posterior, and here's flexor hallucis longus. Okay, so those three muscles in sequence. Now, if you look at the tendons where they go behind the medial malleolus, they go in the order of from posterior to and from anterior to posterior. Tom for tibialis posterior. Tom, Dick, and Harry. I don't know if it was C. Jane Run or C. Dick and Jane. These were reading books in the 50s and 60s. But Tom, Dick, and Harry are popular names back in the middle of last century. If you learn them this way, it would be Dick, Tom, and Harry, which might be easier to remember the muscles in sequence. But if you look down at the tendon, tibialis posterior crosses under the other, so that tendon is Tom. The next tendon is Dick, for flexor digitorum longus. And the most posterior tendon is Harry, for flexor hallucis longus. Harry was my grandfather's first name, so it was easier for me to remember those components, okay? So you can look at your medial malleolus of your model and see the tendon. All of these three tendons cross to get to the bottom of the foot around the medial malleolus. Our lateral compartment muscles are going to go around the lateral malleolus. So there's tibialis posterior. It's going to plantar flex. Come on, plantar flex. Thank you. And evert. Okay. And so it's going to be the more lateral muscle, even though it's going to the more medial toe. That's what I mean by flipped. Okay. And so flexor hallucis goes to the big toe laterally. So it's going to flex the big toe, it's going to bend the big toe down. And it's this one right here. So flexor digitorum, tibialis posterior, flexor hallucis, and here the tendon is going behind the medial malleolus. That's the tendon for tibialis. This is the flexor and the muscle and tendon for flexor digitorum. On the other side of our tibial nerve, the muscle and tendon for flexor hallucis. Okay. So tibialis, well, we'll wait till we get to the anterior leg. So can you guys see that, visualize that on your models? Okay. So just keeping that straight, I think, is the most difficult part. It's not as hard as some of the muscles in the anterior form, but I think it's the most difficult part of what we do have for the lower limb. Okay, once you figure that out, you're home. All right, so now we're ready to move to the anterior leg. Posterior leg was the last group that innervated by the tibial nerve. Posterior thigh is tibial nerve. Posterior leg is tibial nerve, okay? So we're done with our blue nerve over here. And now we're looking at the anterior leg. So if you have your anterior leg on your model, we're looking at, there's actually three muscles on the anterior leg, and unlike the upper limb, there are muscles on the top of the foot when we didn't have muscles on the back of the hand. But we're not going to worry about those. So there is no medial compartment of the forearm, of the leg. All right, we had a medial compartment of the thigh, but no lateral compartment. In the leg, we have a medial compartment of the leg, but no, we have a lateral compartment of the leg, but no medial compartment. All we have is bone there. All right, which you can probably feel on yourself. So anterior compartment of the leg is actually on the lateral side of our anterior border. And the first muscle, if you follow on your model, you can see a tendon coming right down to the first metatarsal. If you look on your foot, you can see that tendon as well. Okay, coming down to your first metatarsal. And it's going to pull on that first metatarsal, just like the tibialis posterior. Okay. Then we have the next muscle that's large is extensor digitorum, and its tendons go all the way to the end of toes 2, 3, 4, and 5. And then between the two, we have just a little flip of a muscle. Mostly what you can see is the tendon going to your big toe. All right, so if you look at your top of your big toe, you can see that tendon pop out as you extend your big toe. Okay? So it makes it pretty easy to find them when you can see those tendons that well on yourself. All of these three muscles cross the foot anterior. Okay? So here's tibialis anterior to the first metatarsal. Here's extensor digitorum longus to all of them. And extensor hallucis is deep going to the top of the big toe. But they all cross in front of the medial and lateral malleolus, which means they can't do plantar flexion. They have to do dorsiflexion. They're going to pull the top of the toe, top of the foot up. So their nerve is the deep fibular nerve. If you pull out the extensor digitorum longus from your model, you'll see the deep fibular nerve deep to it. So it's going to do dorsiflexion, and it's going to share inversion with tibialis anterior, because they both go to the first metatarsal. Tibialis posterior goes to it from the bottom. Tibialis anterior goes to it from the top. Okay? So it's kind of like our flexor extensor carpi radialis. One flexed, one extended, but they both did radial inversion, radial deviation. So for these muscles, tibialis posterior does plantar flexion. Tibialis anterior does dorsiflexion, but they both do inversion. Okay? They're both going to lift the inside of the foot up. What that foot is doing right there. And here's another, that's inversion. Okay, big toe, turning the arch of the foot up, picking it up from the ground. So tibialis anterior is going to do it from this view, and tibialis posterior is going to do it from underneath. Okay, inversion. All right, then we have extensor digitorum longus. Now for the forearm, we just said extensor digitorum. Okay, for the leg, we're going to do extensor digitorum longus. And it's going to cross the foot anteriorly and go to these four toes. So it's going to extend the toes. Okay. These do what they expect. They're where you expect them to be on the leg, so they're pretty easy to find and identify just by looking at their tendons. Okay? So the tendon for tibialis anterior goes to the first metatarsal. You can see that on your model. Tendon for extensor digitorum longus goes to the top of the toes, for toes 2, 3, 4, and 5. And tendon for extensor hallucis longus goes to the top of the big toe. You can see those tendons on all of the muscles. So this nerve, this compartment is innervated by deep fibular nerve. And if you lose that, you change the gait of your walking. Because you can push off, right? You can still push off because you have your tibial nerve. But you can't pull your toes up. So what people tend to do is they push off, and then they tend to drag the top of the foot, lift the foot up, but they can't point their toes, so when they come down to take another step, they come down toe first and then slap their heel down. Instead of coming down heel first and lowering their toes to push off again. Okay? So it's a pushing off, dragging the back of the toes, coming down, toe tap, and then a heel slap. All right? So they can still walk, but it's kind of noisy, and it's not as smooth because there's no other group of muscles that do dorsiflexion besides the anterior compartment. We have two compartments and two nerves that do plantar flexion. All right, that brings us to the last two muscles for lab, and then we have three muscles to talk about just for lecture that are actually in the foot. Okay, question 5. I said it enough times, I hope you remember. Tibialis anterior and posterior share which of the following functions? they both going to dorsiflex? No, because they're coming to the foot from opposite sides. So one's going to plantarflex from the bottom and the other's going to dorsiflex from the top. Do they both do eversion? Neither one, because that's the lateral, that's lifting up the lateral part of the foot, and they're going to the medial part of the foot. All right, so lifting up the medial part of the foot is inversion. So they do more than one of the above, but they're not the same one, okay? They both do two functions, but only one of them is shared. All right, so again, a quick short-term memory question. He's walking properly. I couldn't find a good illustration of the slat heel gait. So what nerve is affected? Now, how do you think this nerve is affected? Coming back up here to our diagram. Remember, this is the right leg. So intramuscular intramuscular injections are done either in the thigh through the deltoid. In babies, you do it in their anterior thigh. Arm through the deltoid. In babies, you do it in their anterior thigh because they don't have enough muscle anywhere else. If it's a lot of fluid, penicillin tends to be 2 to 3 mils of a very thick viscous substance. And so that usually goes in the buttock. And there's a danger area because of the sciatic nerve. All right, so typically when I would give injections when I was still licensed as an RN, I would create an L with my hand, and that would cover up the sciatic nerve, and then I would give, this is a pretty large sciatic notch yet, it wouldn't be quite that big, but I would give my injection in the upper outer quadrant, okay? And that, the sciatic nerve is in the lower inside quadrant. I'd come in and I'd always flat my hand down so they felt that instead of the needle going in. However, if the injection is given improperly, the more likely nerve to be affected is the common fibular rather than the tibial. And so that's usually the reason why the deep fibular nerve is affected. Okay, it's because the most lateral aspect of sciatic is the common fibular, which contains the deep fibular nerve. So components of that are what we see affected. All right, so we have 2 muscles left for lab, and these are in the lateral compartment of the leg, and their 2 tendons pass around the lateral malleolus posteriorly. So this is our lateral malleolus from the fibula. We have 2 muscles, the fibularis brevis, and which is pronis is the old name, and fibularis longus. Okay, fibularis brevis, its tendon comes and attaches right to the 5th metatarsal. Fibularis longus looks shorter, and it's really difficult if you look at the model along the lateral leg to tell which is which, because in the model the fibers blend together. So where I tag it is at the tendon, okay? And fibularis brevis, like I said, attaches to the 5th metatarsal. Fibularis longus actually passes around the lateral aspect of the foot. It goes around the 5th metatarsal, and it attaches actually to the 1st. But it doesn't do inversion because it's getting to the 1st by going under the foot, so it's still going laterally. And so both of these tendons go to the lateral aspect of the foot and pull the outside of the foot up, which is eversion, okay? So this keeps your foot from rolling more outward. It prevents inversion. So here you can see, it should be a dotted line, but you can see how the fibularis longus tendon goes all the way across from lateral to medial on the inferior aspect. I was telling the class last night, I actually killed my superficial fibular nerve giving birth to my oldest child. I pushed for about 2 hours, so every minute or 2, I was grabbing my knees and pushing. I'm not going to illustrate that part to you. But you grab from the outside, right? And the lateral bone is the fibula. So the heel of my hand would compress the fibular nerve against my fibula for a minute or so, every minute or two. And after 2 hours of that, it was dead. Same thing can happen with a cast or wearing ski boots that are too tight. And I didn't know anything about it. He was born the end of August. It was hot. I was wearing flip-flops. He was born on Monday. We go to church on Saturday. And so I went into my closet to get dressed for church. And my heels were only about an inch, inch and a half tall. I could not walk out of the closet. So if these muscles weren't working, what was my foot most likely to do? This or this? Rolled out. Okay? So I was completely unstable on just even a little heel because it just rolled right out. Now when peripheral nerves are killed like that and die, they usually die back almost to the spinal cord. And then with Schwann cells still present, if they're healthy, they provide a growth factor and a pathway so that the nerve knows where to get to, but it only grows about 1 to 2 millimeters a day. So it took me from August to almost May to get that function back. And I also had loss of anesthesia, paresthesia along the side of my foot. That's still there, but I have function back at least. Okay, so like I said, a cast that's too tight along the bone there or ski boots that don't fit along the bone there can compress the common fibular nerve or its components at that side. All right, so that's the last of the muscles that you need to identify for lab. And then, like the hand, we have more muscles, but only 3. Okay? So the first one is actually a deeper muscle. You're not going to see it if you look on the bottom of your leg model. If you look on the bottom of your leg model, you're going to see this muscle right here, which is flexor digitorum brevis. That's the one that's like superficialis. It has the fork. But if we take that muscle off, then we see the tendon coming around the medial malleolus for the flexor digitorum longus. See how it comes in at an angle? So it's going to pull when it causes those toes to flex. They're not going to flex straight back like this. They're going to flex over that way because that's the way the angle is of those tendons. So the first muscle that I want you to know is this one right here, called the quadratus plantar. A shape of a quadrangle, and found on the plantar surface of the foot, and it pulls on the tendons, flexor digitorum longus, to straighten out the flexion of the toes. Okay. And the other 2 muscles are easy. They're what we had in the hand. So we don't have a weird movement of the toe like we did for the hand because we can't oppose our big toe to our little toe. So abduction of the toes is exactly like we see for the hand, only the second toe is our midline, whereas in our hand it was our 3rd finger. And so abduction of the digits are all the same, they're all on the same plane. So the muscle that abducts the little toe is abductor digiti minimi. And we use the abductor of the big toe, because it's going to be abducting in the same plane, right? So abductor hallucis. Well, those are going to do back for the toes. We're not going to worry about interossei for the feet. We have them, but we're not going to worry about them, okay? So the 3 muscles I want you to know for lecture, I want to ask you to identify them for lab, and you don't have to know origins, just know what they do. Quadratus planti, which straightens out the flexion of the toes for flexor digitorum longus, and abductor digiti minimi and abductor hallucis. We're done. Well, you're not done. I'm done talking. You still have studies to do. Let me see if Jeff is here. All right. And last night I moved the cadavers into that room because it's straight and from the cadaver room rather than trying to angle it in.